Renal artery stenosis. Summary. Renal artery stenosis, a narrowing of one or both renal arteries, primarily results from atherosclerosis or fibromuscular dysplasia, leading to secondary hypertension due to reduced renal blood flow and activation of the renin-angiotensin-aldosterone system. Understanding the diagnostic findings, treatment options, and specific medications is crucial for specialist pediatric doctors. Diagnostic findings: hypertension, early onset, severe, resistant to conventional therapy. Abdominal bruit, audible over the flank or epigastrium, present in both systole and diastole. Imaging: duplex ultrasonography, initial non-invasive screening. CT angiography, MR angiography. Confirmation, particularly for atherosclerotic RAS, risk of contrast-induced nephropathy. Renal artery angiography, gold standard, delineates the site and severity of stenosis. Findings: proximal stenosis, atherosclerosis, distal string of beads, fibromuscular dysplasia, ipsilateral renal atrophy. Treatment overview: antihypertensive therapy, primary management to control secondary hypertension. Monitoring: essential after initiating ACE inhibitors or ARBs due to the risk of worsening renal function. Pharmacological management: 1. Antihypertensive drugs, ACE inhibitors, e.g. lisinopril, enalapril. Class: angiotensin-converting enzyme inhibitors. Mechanism: reduce angiotensin II production, lowering peripheral resistance and aldosterone secretion. Angiotensin II receptor blockers, e.g. losartan, valsartan. Class: angiotensin receptor blockers. Mechanism: block the action of angiotensin II at its receptor, leading to vasodilation. Calcium channel blockers, e.g. amlodipine, nifedipine. Dihydropyridines. Mechanism: inhibit calcium ion influx through L-type calcium channels, causing vasodilation. Beta blockers, e.g. atenolol, metoprolol. Class: beta-adrenergic blockers. Mechanism: block beta-adrenergic receptors, reducing heart rate and contractility. 2. Monitoring: serum creatinine, post-ACE inhibitors or ARBs initiation to detect renal function deterioration. Electrolytes, especially potassium due to the risk of hyperkalemia with ACE inhibitors and ARBs. Revascularization, indicated in hemodynamically significant stenosis with resistant hypertension, recurrent pulmonary edema, or renal function deterioration. Procedures: percutaneous transluminal renal angioplasty, PTRA, with or without stenting, particularly for fibromuscular dysplasia, surgical revascularization for complex atherosclerotic cases. High yield points for specialists: renal function monitoring, essential after initiating ACE inhibitors or ARBs in RAS patients. Revascularization, considered for significant stenosis with complications despite medical therapy. Differential diagnosis: RAS should be differentiated from other causes of secondary hypertension, particularly in pediatric populations with early onset hypertension. This summary provides a structured overview to aid specialist pediatric doctors in diagnosing, managing, and educating on renal artery stenosis, emphasizing critical pharmacological details and procedural options. Clinical case: pediatric renal artery stenosis. Patient information: age, 12 years, sex, female. Medical history: no significant past medical history. Normal growth and development. No family history of renal diseases, but a paternal grandfather with a history of early onset hypertension. Presenting complaint: the patient was referred to the pediatric clinic for evaluation of newly diagnosed hypertension during a routine school health screening. Blood pressure readings were consistently above the 95th percentile for age and height on 3 separate occasions. Clinical examination: blood pressure 150/95 mm/Hg in both arms, sitting position. Physical examination: generally well, no dysmorphic features, normal body mass index, no abdominal masses palpated. A faint bruit was auscultated in the right upper abdominal quadrant. Normal heart sounds, no murmurs. The rest of the systemic examination was unremarkable. Investigations: basic metabolic panel, within normal limits except for slightly elevated serum creatinine. Urinalysis: normal, no proteinuria or hematuria. Renal ultrasound: normal kidney sizes with no structural abnormalities. Doppler ultrasound suggested turbulence in the right renal artery. Echocardiogram: normal cardiac structure and function. Differential diagnosis: primary hypertension, renal artery stenosis, RAS, due to fibromuscular dysplasia given age and sex, coarctation of the aorta, endocrine causes, e.g., pheochromocytoma, hyperaldosteronism. Further diagnostic workup: magnetic resonance angiography, MRA, revealed a beaded appearance in the mid to distal right renal artery consistent with fibromuscular dysplasia. Diagnosis: renal artery stenosis secondary to fibromuscular dysplasia. Management plan: 1. Medical management initiated on a low-dose calcium channel blocker amlodipine to manage hypertension and monitor blood pressure closely. 2. Interventional procedure: given the clear diagnostic imaging and symptomatic hypertension, the decision was made for angiographic evaluation and possible percutaneous transluminal renal angioplasty, PTRA, without initial stenting to correct the stenosis. 3. Follow-up and monitoring: regular blood pressure monitoring post-procedure. Serum creatinine and electrolytes to be checked 1 week post-procedure, then monthly for 3 months. Repeat MRA 6 months post-procedure to assess for recurrence of stenosis. Discussion points: importance of considering secondary causes of hypertension in pediatric patients with new-onset hypertension. Role of non-invasive imaging in the diagnosis of RAS, with MRA being a preferred modality in pediatric patients to avoid radiation exposure. Indications and expected outcomes of PTRA in pediatric RAS due to fibromuscular dysplasia. Follow-up: the patient's blood pressure normalized post-procedure, and she remained asymptomatic with normal renal function at the 6-month follow-up. The repeat MRA showed no recurrence of stenosis. Long-term follow-up will focus on blood pressure monitoring and periodic renal function assessment.